So let me begin with an introduction of our panel. Please hold your applause until I've introduced all of them. I will ask the panel members to stand as I introduce you. So starting on my far left, your right, is Lynda Tanner, President and CEO of Visiting Nurse and Hospice Care.
So Mike, I'd like to just take this opportunity to welcome everyone here tonight, and especially to welcome my colleagues here that agreed to come and serve on this panel. It's a privilege to be up here with you, and I want to thank all of you for the wonderful health care that you provide for Santa Barbara.
Dr. Kurt Ransohoff, super talented physician. He knows exactly who he is. Even if I don't. Specialist in internal medicine, and he is the CEO and Chief Medical Officer of Sansum Clinic. And in this capacity, Dr. Ransohoff oversees the largest outpatient healthcare delivery system in Santa Barbara County. Thanks for being here, Kurt.
Thank you, Mike.
Now, Dr. Bentley. Dr. Bentley's been practicing gastroenterology in a small independent group setting in Santa Barbara for 28 years. He served a leadership role in many local healthcare organizations and has expertise in Medicare payment, small group practice accreditation, and quality improvement. Next. To double check now. Bob Freeman, Chief Executive Officer of CenCal Health, which administers several publicly funded healthcare programs for low-income residents of Santa Barbara and San Luis Obispo counties. The primary one being the Medi-Cal program. Very important job and big responsibilities for Bob. CenCal was one of the first Medicaid-only managed care plans in the country. We have Dr. Fred Kass. In addition to practicing clinical oncology for over 25 years, is also the Medical Director of Research and Wellness for the Cancer Center Santa Barbara with Sansum Clinic. And Ron Werft, President and CEO of Cottage Health System, a place we're all familiar with, 3-hospital not-for-profit system that provides a level and quality of care and breadth of care that a community of our size is really fortunate to have. Ron's also the past chair of the California Hospital Association and is very knowledgeable about healthcare, as you're about to find out. Thank you all for joining us. As we were planning for this panel discussion, it was suggested that I also introduce what I'll call the elephant in the room, which is the Affordable Care Act. So let me say a few words about the Affordable Care Act, just to kind of set the table and get all of us on the same page about what it actually is. The Affordable Care Act, also known as Obamacare, was signed into law March 23rd, 2010. It's almost exactly 4 years ago. It was enacted with the goals of increasing quality and affordability of health insurance, lowering the uninsured rate, and reducing the cost of health care. The ACA represents the most significant regulatory overhaul of the U.S. healthcare system since 1965, when Medicare and Medicaid laws were passed. It was widely agreed that healthcare legislation was long overdue at the time it was passed, even if there wasn't wide agreement on other things. But the legislation was broadly supported by a number of interests, including business leaders, physician groups such as the American Medical Association, the AARP, hospital associations, and many healthcare economists. So I'm just going to briefly review its main provisions. So first, in an effort to improve access and affordability of healthcare, the ACA expands Medicaid, which we call Medi-Cal in California, or for most people, CenCal in Santa Barbara. It expands that to people with incomes up to 138% of the federal poverty level. It offers subsidies on a sliding scale for people making up to 400% of the federal poverty level. That's $46,000 a year for individuals, or $94,000 a year for families of 4. So those people would be eligible for some type of subsidy on a sliding scale. The ACA prohibits insurance companies from denying coverage or adjusting rates based on people's pre-existing conditions, and prohibits adjusting rates based on gender. It creates health insurance exchanges where individuals and small businesses should be able to shop for and compare policies and access government subsidies if they're eligible. And it creates a mandate for larger businesses to offer insurance for their employees and for individuals to purchase insurance or pay a penalty. To improve the value of healthcare, which in the healthcare world generally means good outcomes for a reasonable cost. To improve value, the ACA created minimal standards for what insurance policies are required to cover. It attempts to create new payment systems where fees are linked to outcomes and quality measures, not just to the volume or number of things that are done. And it attempts to enlist doctors, hospitals, and healthcare systems and other providers to participate in controlling costs with a series of reforms and experiments that move Medicare payment systems from fee-for-service payment models toward bundled payment models. An example would be a single payment to a healthcare system for a knee replacement rather than paying individual fees for a doctor, a hospital, a visiting nurse, and other individual services. So needless to say, the ACA, as it was written, was very ambitious, both in its scope, and we're finding it's in the time frame in which it's being implemented. Some of you may have heard that it has hit a few snags along the way. So with that, there's the ACA crash course for you. And we'll talk more about that. And actually, the first question I want to pose to our panel, I'm going to start with Ron Werft, and it has to do with the ACA. And essentially, this is a question that we all get asked all the time. From your perspective and your organization's perspective, what is the biggest challenge that the ACA has brought? And if you please, what are the biggest opportunities that the ACA has presented?
Thank you, and thanks for that introduction too. That was a really succinct introduction of the basic elements of the law. So there are a lot of technical issues that hospitals are dealing with, including ours, that have to do with the details of the law. But I don't think that those are the biggest challenge for hospitals or for Cottage. We are both a provider of acute care hospital services. We also have a self-insured group health plan. So for our employees, so we're a plan as well. And so there are technical aspects that have to do with being taxed for providing too good a plan by the year 2018. And we could talk about those kinds of things. But I think for us, the biggest challenge is just the uncertainty. The uncertainty of what's going to happen nationally at our state with Cover California and the insurance exchange. What plans will be offered. It wasn't until very late last year that we knew there would only be 2 plans offered for the individual PPO market, and that caused a lot of disruption in the marketplace. And even today, it's very difficult for consumers to know, and this was the goal, really, it was to get good information in front of people to make good decisions. It's still very difficult for people to know exactly what they're buying in terms of the physician network or the amount of copay, the maximum deductibles. Those challenges are very real for people, and I think that we're not yet really, enough time hasn't gone by yet for us to see some of those problems. We think at California Hospital Association that we're going to see really this summer, fall, a lot of people realizing that they have purchased plans that have 30% copays, but didn't really know that until they needed to access the system. And that's going to be, I think, a real problem for people. So, uncertainty. What will the employers do? Will employers continue to provide commercial insurance as an important benefit to their employees for recruitment and retention of our workforce, which is a lot of our systems based on that? Or will they provide vouchers now that there is an alternative for employees to seek their plans through exchanges or elsewhere? So really uncertainty. It's becoming more and more difficult for us to project 5, 7, 8 years out on what it's going to look like. And we have to make decisions on acquiring capital equipment that's multi-million dollars, and we really have to we want to know what those revenues particularly are going to look like. What is certain is provider cuts. We know that Medicare is going to be cut back further to physicians and to hospitals, and that part is very certain. I think a lot of the cuts were predicated on the presumption that we were going to solve a large portion of the uninsured problem. So big uncertainty is how many people are going to sign up, and if we can absorb, as a hospital, can we absorb those reductions in government reimbursement for the entitlement programs and hope that there will be more people on Medi-Cal for which will be paid, where in the past we would receive no compensation for uninsured. On the opportunity side, I think it's a really exciting time. We had a system and have a system that, in my view, is not sustainable. The amount of premium increases that were being passed on to employers and individuals is just not sustainable. And so we also, as a nation, cost more than any other developed country. You all know that. And so something really has to change. And I think whether it's exactly the way it's written now or whether it's changed in the future, we do have an opportunity. Those people who are in the system now and elected officials have an opportunity to make something better than what we've had. So we've got pay for performance that is holding hospitals more accountable for patient harm events, for quality of care, for patient satisfaction, for readmission rates, and we're being rewarded or penalized financially through the ACA for that. And I'm taking more time than I should here, so I'll just mention the last one, and Dr. Bordofsky mentioned this. There's a real encouragement through demonstration projects and through payment reform for organizations and individuals who have heretofore been silos in our system to partner in new ways. And I think that's very exciting through accountable care organizations, through clinical integration, through economic integration as well. I think that will help us do a better job. And at the end of the day, hopefully we all have the notion of putting the patient really at the center of all of this, where they should be.
So in cancer medicine is kind of the, if you're trying to control healthcare costs, we're the red sports car on 101 going much too fast. The great thing about having an opportunity to participate in cancer care in this era is the absolute excitement that happens on a regular basis as new discoveries are made. New parts of the genetic puzzle are solved. New drugs that come on the marketplace that a generation ago no one would have thought possible. The downside of that is that each succeeding generation of therapies dwarfs significantly the cost of what it replaced. So as we try to participate in things like bundled payments, or other programs in which we're trying both to deliver great care and to control costs, it becomes very difficult because you just don't have a good sense of how the science is going to evolve and therefore how the cost is going to evolve. The issue that Ron Werft talked about people discovering their patient responsibility portion of insurance is huge in cancer care. Because if you're responsible for 20% of the drug that costs $1,000, that's one thing. It's another thing to be responsible for 20% of the drug that costs $100,000. These are problems that we struggle with all the time. On the upside, I have to say that having been in the community for a couple of decades and having had a lot of experience over the years attempting to provide the very best care to everybody regardless of insurance, it has become particularly challenging in recent years to summon the resources to provide state-of-the-art cancer care to the uninsured in our community. So any effort that whittles that down, that somehow cuts down the number of patients without insurance is a huge interest to us, as is any effort to deal with the issue of pre-existing conditions, as you can imagine, for our patients, whether they have cancer or whether they participate in our genetic counseling program and find that they carry a genetic burden that makes them susceptible to cancer. all of these patients are very concerned about their insurability. So that portion of the law is obviously quite welcome to us and to our
Okay, for us, in terms of challenges, I think there are three that were pretty straightforward. The first is just growth. Over the next 2 years in both counties, we expect to add about 30,000 new members or patients into our deliveries. So we're about 115,000 now, so we'll be about 140, 150,000 by the end of 2015. So the big challenge we have is preparing for that. And that pace of growth and that level of growth over, a fairly short period of time. So what we really had to do is find out where we're going to get the physicians to treat all these, to be the primary points of contact. So we spent a lot of time working with our clinics, neighborhood clinics, county clinics, and so forth, to figure out, okay, these people they're not moving into the area, they're here, but where are they getting their help? And so we really determined that about 80% of the people that are going to become Medi-Cal eligible in the next 2 years, they're getting their care at these clinics, but either as a no-pay or private pay. So the idea is, okay, how do we get these people into an organized delivery system? We don't want them coming just episodically when you're sick. We want them on a regular basis. We want them to get preventive care and so forth. But even with that, we knew we had to add additional physicians to our network. So again, I'm always talking both counties, but we added about 100 new physicians over the last year to both primary care and specialists to help deal with these influx of people that will go from not being in an organized delivery system of care to one that is very organized. And we want to make sure there will be specialists if there need to be referrals and so forth. So the growth was a big challenge for us. And to complicate things, in the middle of this, in July of 2013, about 8 months ago, the state comes to us and other plans like says, oh, by the way, we also want you, beginning January 1st, to cover mental health benefits. Right now, in the Medi-Cal system, you have what the mental health services that a primary care physician would cover in their normal scope of practice, and then you have the severe mentally ill that the county mental health departments would cover. And in the middle, you had nothing. So the state's saying, well, we want you to cover these benefits. So basically, between July of 2013 and January 1st, we had to build a network of psychologists, psychiatrists, licensed clinical social workers, etc., from scratch and have it ready to go by January and be ready to start delivering services. So we do now have a network of over 150 of these providers in both counties. So now the challenge with that is the state's said all that, by the way, they can't pay us for the next 6 months. So we're actually providing it for free until they get around to paying their bills. And then the last challenge, I think, that was interesting for us was outreach. We were very concerned as the Affordable Care Act implementation was coming up. It's like, do people know about this? Have they focused on it? So we put a significant effort in, along with the county, both counties, to really get the word out. We want to make sure our own providers that we contract with are trained. What are their providers' offices? What are they going to know? Do they understand what the exchanges are? Are they going to know that we're going to be expanding? So we did a lot of presentations up and down the service area to provider offices. And we also did town halls with the county and just doing our best to get the word out. We did press releases, interviews on radio shows and so forth, because we really were concerned that people would start focusing until November, December, and then there would be there's a whole lot of uncertainty and confusion. So I don't know how much worse things would be or not if we did this, but I think if nothing else, our provider community was much better prepared for the changes the Affordable Care Act brought about. And then on the opportunities, I'll just be brief on that. I think the biggest opportunity is that we're really going to be able to reduce the number of the uninsured, which will transition to our program, and that will mean there will be less uncompensated care that hospital emergency departments have to deal with, or the community clinics or county clinics have to deal with, and then they will be getting reimbursed, and we think that's a good thing. And also get these people that have not had organized care and have been going to the doctor only when they're really sick to get them into a regular course of treatment. So if they have bronchitis, it doesn't turn into pneumonia because they've let it go. So with that,
I'm giving the perspective of somebody who's had a career in independent small group practice. And there are a lot of us in this community and also across the country. I think it's kind of ironic, Bob, that your challenge is finding enough providers. And from our perspective, our concern is being able to stay in business as independent small group providers. What's in the ACA is pretty scary to all of us. There is a lot of uncertainty, and I know not only locally, but with other independent care providers that I've talked with in the state and at the American Medical Association meetings, they share the same concerns. I'm in this type of practice because autonomy is important to me. I have a vision, a particular vision of how my practice should be, from where I practice to who I practice with, and how much time I spend with my patients. So autonomy is very important. And that autonomy is associated with a high degree of physician satisfaction. It's also associated with a high degree of patient satisfaction. But it comes at a cost. And it's our belief, really, that policymakers have targeted our type of practice as the problem that has led to unsustainable growth in healthcare costs. The goal of the ACA, as Mike had mentioned, really is to convert our current system into one that develops high-quality care at a affordable cost. 30%, some policymakers or studies have demonstrated that 30% of the care that we provide to our patients really has no demonstrable value to them. So organized healthcare systems such as Kaiser Permanente and Mayo Clinic have been shown to provide very high quality care and do it in a very efficient, cost-effective method. I think if independent practitioners are going to stay in business and survive with these changes, it's going to be very important that we figure out a way to do it in much the same way. That's quite a challenge. On the other hand, though, as our other speakers have mentioned, challenges present great opportunities. And one of the greatest opportunities, I think, with this act is that it opens the door for physician leadership on these types of changes. The transition, it's expected that physicians are going to play a big role in that transition. We have the opportunity really to make sure that these quality improvements are meaningful. So I think that's really up to not only the independent physicians, all the physicians in this community to see that happens.
Well, since I'm going towards the end, I'm going to tell a story about and this story it may resonate a lot with you at the moment. About a year ago, Sansum Clinic sponsored Abraham Verghese to give a speech at UCSB. And my job was to interview him on stage. So I went backstage, and he's a physician, and I went, he's this noted author and just a tremendous person, and I said, what would you like me to talk about? He says, you can talk about anything you want. I said, okay. And then he waits for a second, he goes, just don't ask me any questions about the Affordable Care Act. And I said, well, why? And he said, well, because it's mind-numbing. So I hope that part doesn't resonate with you at the moment. Let me now echo a lot of what my colleagues have said. The biggest challenges from our standpoint are uncertainty. We prepared for X, Y, and Z to happen because X, Y, and Z had been voted on, had been widely publicized, and we made a lot of preparation for that. And then the complicated politics swarming around this meant that suddenly we find out it's going to be X and Y and Z is going to be delayed. And then the next thing we know is it's going to be X and a part of Y, and Z is going to be delayed. In the meantime, we've made very big decisions that have huge impacts on our budgets and on people's jobs and people's careers. So that uncertainty is really problematic. It exists at the level of information. There's still a tremendous amount of uncertainty. People have a hard time looking up and figuring out what kind of insurance do I have? What network of doctors can I go to? So that information uncertainty is huge. Payment uncertainty. At the end of February, we had been paid 3% of our billings to the covered California plans. So my 6th grade math, just to put this in perspective, is $100,000 of billings, we've been paid $3,000. Now I'm sure that eventually they'll get caught up and we'll get paid $4,000. I'm sure it'll get caught up and we'll get paid some reasonable amount of money, but it points out just the uncertainty in the systems, again, that this goes live and we're just not really prepared for it. Final uncertainty is just patient's behavior. We've seen some very curious things that we haven't seen before, which is the introduction of seasonality. In the past, you could always anticipate that the winter months would be busy because of colds and flu and whatnot. But this year we saw that November and December were phenomenally busy for us. And then January and February were not, and it's because people are dealing with their deductibles. They're trying to squeeze healthcare in at the last minute of the year because they met their deductibles. And then in the beginning of the year, they're not. I had a patient the other day who has a new insurance policy. Anytime he chest pain, he needed a treadmill and so forth. They said, can you code it as a physical? Because if I code it as a physical, it doesn't apply to his deductible, which is awkward, right? For somebody who has chest pain. So, again, we're just seeing all sorts of different behaviors that we haven't seen before. The opportunities, no question, it's, in my opinion, it's patients getting care who couldn't get care before. I remember as a resident, and ever since then, running into people who have horrible illnesses and were excluded from the insurance market, and they had no way of getting in. Or people who kept their jobs because it was the only way they could get insurance, or they just couldn't afford it. And most of those issues are getting dealt with. And frankly, the benefits of that actually outweigh the downsides. Well, I'll have to get back down that 3%. And finally, I do think another opportunity has been alluded to already is the opportunity for change. The system is broken, it's extremely expensive. Santa Barbara isn't as wasteful as other places, and I'm sure we'll talk about that later, but there's just great opportunity to have a better system, and if this is a catalyst for that, that'll be worthwhile.
So, thank you. I also, the uncertainty certainly is a point with Visiting Nurse Hospice also. It's really hard to plan. But as far as challenges go, one of our biggest challenges at the moment is the ACA requires Medicare to reduce the base rates for providers over a 4-year period beginning this year with a maximum reduction of 3.5% per year. So that's called rebasing. And so what that means for home care, which is what I'm going to speak to, but all these other organizations are facing the same thing. This is going to result in 14% decrease in our reimbursement between now and 2017. And even Medicare predicts that because of this, 40% of the home care agencies across the country will have to close. and our National Trade Association is predicting 60%, because the margins they're very little right now, very small, and then when you add that, and that, on top of that, then we all have had to deal with sequestration, which was a 2% cut off the top that occurred last year, and that's continuing at this point into the future. So with less payments from Medicare and expenses rising, the rural areas really won't be able to have home care anymore. And so while the whole Affordable Care Act really is all about reducing expenses, this is going to actually increase expenses because people won't be able to be cared for in the home, and they'll have to then seek emergency room and hospital care. So it's an interesting dilemma, and I think there's a purpose behind it in that they're trying to close a lot of the smaller agencies, and they're really looking for the larger organizations to come together and have, the big organizations instead of the smaller ones. But I think that there will be some loss there, particularly for the rural areas. The hospice benefit, as we know it, is currently under attack in Washington right now. Reimbursements at risk, along with added regulatory coverage requirements. So this ultimately pushes up the cost, and it's a constant stream of change. As many of you talked about that uncertainty, it's difficult to keep up and know quite how to plan. And then the third one that I wanted to speak about is MedPAC is currently recommending $100 to $150 copay for patients per episode of home care for patients without a prior hospitalization. So that means that patients that are referred directly from a physician's office, they would have to pay $100 to $150 for that episode. And while that doesn't sound like a lot, that is a lot to many of our patients out there. So the problem with this thinking is that patients will not utilize home care due to the copays, and then they'll end up back in the emergency room or the hospital, or they'll seek high-cost hospital care first in order to avoid the copay, much like Kurt was talking about, could you code this as a physical? So I think this is very convoluted logic, and quite frankly, I can't figure out what the advantage is, but this is what they're discussing right now. So our challenge really is the same challenge as many of the other organizations that are up here. Reimbursement cuts, mounting administrative regulations, mounting staffing and operating costs, and healthcare reform pressures with increasing complexity. And our goals: reduce our costs, maximize our reimbursement, reduce readmissions, and improve care, and increase patient and customer satisfaction. So those are the challenges that we have, and really it's a challenging time. As far as, I'll just spend a minute, because I've taken most of my time on what's the opportunity. I agree here with my colleagues. I think change is a great opportunity, because I think that we all concur that currently our health care that we have now is not optimal. Many people are getting care that they don't want. There is some value missing in some of our spending, and we need informed consumers. So the piece that I'm the most excited about really is patient-centered care. The goal of the ACA is to quit paying providers silos. I think that was mentioned up here. Instead, to share payment between providers for improved quality at lower costs. So instead of payments that support how much did you do, the ACA is clearly trying to move us towards payments that support how well did you do it, and more importantly, how well did the patient do it? How well did the patient do? So as part of value-based purchasing, the ACA is looking at organizational, clinical processes, efficiencies, outcomes, and the patient experience. And these are the areas where we will all be incentivized to improve in the future. These are the areas that will enhance our healthcare system. So no more silos, but instead working together to achieve the best outcome for the patient. So that's where I see the opportunity.
Thanks, panelists. We've got an eye on the clock here, so this would be a good time for people, if they have questions, to pass them toward the aisles so we can start to collect those. Also, just going to ask our panelists to, we're asking open-ended questions, but if there's any way to ease this thing, we'll get through a few more of them than we will otherwise. Let me just jump right in. The next question I have, and I'm going to direct it to Dr. Bentley first, is about integrated and coordinated care. We hear about that. We hear about integrated, high-quality care as a goal, and I think we probably all agree that that would be a good thing. But From your perspective, I mean, what does that look like? What is your vision for integrated, high-quality care? And the other panelists can address this as well, but it would also be nice, I think, for our audience to hear maybe some examples of things that your organizations are already doing that are helping improve care integration and coordinate care better.
Well, from, again, from the perspective of a independent small group practitioner, I would hope that this would be a common vision. I mean, if you look at our current healthcare system, it's very fragmented, and as Lynda had sort of alluded to, I would say it's very provider-centric. And really what we need to do is reorganize. We need some good leadership to reorganize. Trying to get doctors to buy into change is extremely difficult, so it's going to require good leadership in the community. And part of that is having a common vision. Now, certainly care coordination is going to be an important part of that vision. We're going to need a common platform to carry this out. That involves having proper information technology so that we can carry this out. And it's going to take additional resources to be able to provide nurse care managers. There's going to be additional physician time in care management. But in order to fulfill the requirement for these resources, we're definitely going to have to somehow change the way that the current payment schedule is addressed. Right now, the payment schedule doesn't reimburse for time. It doesn't really reimburse for physician care coordination, and that's probably why most of the care coordination that we see around is driven by nurses. I certainly agree with your comments that this vision has to be patient-centric, and it really has to be patient-centric across the entire continuum of care, not specific to particular providers. So there's a much bigger picture here. The vision includes all modes of practice, all providers, and I think it's something that the entire community really needs to get together and figure out.
From Sansum Clinic standpoint, we've done a couple of things. We affiliated with the Cancer Center, which was a big step in trying to just better coordinate care. We now have one medical record that we share. We are trying to get closer with the hospital, and the hospital I know wants to work more closely with the independent doctors, both of which are excellent things to try to improve coordination. Well, we've made some huge investments in infrastructure. We installed a computer system called Epic, which is the same system that UCLA, UC San Francisco, curiously all of the UCs except Irvine, it's an Orange County thing, I guess, that they are not going to go to Epic. But it's a wonderfully robust computer system, and it allows, for instance, if a patient of ours shows up in the emergency room, they can log in 24/7 and see exactly what was the green pill that the doctor gave you yesterday, and what's been happening with you over years, actually. So that's very valuable. We've actually enhanced that module so that all the doctors in the community can get into that system and see what's going on with patients of theirs. You might be interested to know that that system allows patients to get into it directly, and then they can be part of the coordination by making sure that we think they're on the same medicines that they're actually on. And we actually have 49,000 Santa Barbara people have signed up for that system. So that's quite, I don't know how many here, I'm just curious, have signed up. So it's about a quarter. It's quite a lot, actually. Just fun fact, we've had as many 90-year-olds as 20-year-olds have signed up for that system. So, the other thing we're piloting a new project where Jack and Julie Nadell made a donation to pilot a project where we have a pharmacist now calling patients who are being discharged from the hospital on complicated medicine regimens and getting put on complicated drugs in the clinic to make sure that they know what they're doing, that they've gotten the medicines right, and so forth. So we're making a lot of efforts to try to better coordinate care.
So I'm going to speak just a minute about my vision of ensuring integrated care in Santa Barbara. My vision is that there would be partnership across the continuum, seamlessly share data more easily, have triggers for automatic referrals to keep elderly seniors safe at home where they want to be. Home care qualifications would be based on risk and chronicity and not just homebound status. Healthcare's focus would be on the most effective way to care for patients and not about the site of care or who will be paid. We would have shared risk. And a focus is care coordination, as Dr. Bentley spoke about, would be, I would especially like to see that focus as it relates to chronic care management. Because I think as our seniors are aging, and we have, I think it's, 10,000 people a day going on Medicare. Age 6, I've got it right here somewhere. I thought 10,000 baby boomers turn 65 every day and qualify for Medicare. So this is happening. 83% of those beneficiaries have at least one chronic condition, and 23% have 5 or more chronic conditions. So and that accounts for 68% of all of our Medicare spending. So I think that we have to really find a way to focus on chronic care. Another part of my vision is that healthcare will move to the home. Technology advances will increasingly enable at-home healthcare for patients. Partnerships will expand to facilitate new approaches to care delivery as we strive to better manage the health of patient populations. So ideally, I think it's been mentioned up here already, I'd like to see us move from fragmentation to collaboration, move from specialty-driven to patient-driven care, revenue to be linked with quality outcomes, and utilize proven interconnected technology along with data to better serve our community.
Yes. One point I would make is that a lot of reform was just happening and is continuing to take place, sort of regardless of the Affordable Care Act. I think the Affordable Care Act is one part of this, but as we've all talked about, the problems with the current system, that was becoming apparent. We were seeing a migration to high deductible plans, and at the bottom of that is really doing everything that we can to reduce the cost of care, because it has become unaffordable for a lot of people, but also to eliminate any unnecessarily duplicated or just unnecessary services, and to really get at that. There's a lot of things we do in our healthcare system that just doesn't add value. So I think one of the encouraging things is look at the attendance tonight. The amount of interest in this topic is enormous, and we're seeing really creative approaches from within our organizations that are getting at that are not so much a response to the Affordable Care Act as they are just a response to the problem. So at Cottage, I think there's some of the examples I would mention. That there's now in our community, we have individuals who access and come to the emergency department for care on a regular basis, 150 times a year, 200 times a year in our community. And so really from the ground up, some of our staff really saw this, what can we do about this? And then what came out of that was what we call the Monday Huddle. And it's a unofficial partnership of social workers from Cottage, from the County of Santa Barbara, from the Rescue Mission. We have parish nursing, that's a program that we provide, but it's funded entirely by the St. Francis Foundation. Just recently, with a conversation with Doctors Without Walls, who provide care in the homeless community, have been invited to participate in this also. And it's identifying patients that if they can find out a home for them to get care that isn't the emergency department, and to help them with their medications, to whether the care is best delivered literally on the street or in a county clinic, like the Santa Barbara neighborhood clinics, it's had an enormous effect on providing care for these individuals much more economically, but also much earlier in their care process. So they aren't in need of very high expensive services or inappropriate services. That's not what the emergency department is for. So I'm really encouraged by that. We just got a grant from the UniHealth Foundation that we're just launching a program for chronic and high-risk case management that is intended to get at patients who are discharged from the hospital with chronic conditions, high likelihood that they may be readmitted, but same idea. Let's help them with their medication management. Let's help them, even if it requires assisting them to get to a doctor's appointment, let's help them do that rather than wait until they need to access the hospital again for high-cost acute care services. Our medical residency program, we have 54 residents in internal medicine, general surgery, and radiology, and they provide care for patients at the county clinics. And so when those patients need to be hospitalized, there's a care system in place for them. So we have that continuity of care between the county and the hospital for that population. And the last one I mentioned that does come right out of the Affordable Care Act is now hospitals are required to do a community needs assessment in a certain way every 3 years. And we just did ours and have sent it out. And it identifies through a lot of interviews and also looking at data what the gaps in our community are by medical discipline. And it's an opportunity to work with other parts of our healthcare team, as you see here on the stage, but also to work with our local philanthropic foundations in providing support for getting at some of our problems, whether it's in oncology or cardiology or care for the homeless or access to insurance, which are some of the things that pop up in this.
About 3 or 4 years ago, a group of us in cancer medicine who were involved in breast cancer came together to create what became known as the Breast Cancer Alliance. Our initial goal there is a national program that certifies breast cancer centers, get certified as a center with a certain level of expertise. Our goal is to do that here in Santa Barbara. Up until the time that we started to put together a committee to do this, these centers, and even to this day, are almost exclusively in places like academic medical centers where all the practitioners who are involved in that care all essentially work for the same employer, all work for the university, all work for the same health clinic. We had a different vision. We called our vision a center without walls, simply because there was no set of walls in Santa Barbara within which you could find all the practitioners who are interested in breast cancer. So we set out to see if we could create a coordinated effort in this one area that crossed all boundaries. So we created this steering committee. It was kind of like a Noah's Ark of breast cancer. We had a couple of radiologists, we had a couple of pathologists, a couple of radiation oncologists, a couple of medical oncologists. Everybody that could be involved in this came to a steering committee, and some worked in solo practice, some worked for small private practices, some worked at Sansum Clinic, some worked at the hospital. Those early meetings, I'm quite grateful that, in retrospect, that they weren't recorded. Let's just say that we didn't come to consensus at the first gathering. But it happened, and about a year later we were certified, and this last year we were recertified for another 3 years, and the cornerstone event of this group is that every Wednesday we all get together in a conference room, and now we're talking about pathologists representing the 2 major pathology groups in Santa Barbara, radiologists representing the 2 major radiology groups in Santa Barbara, practitioners from Sansum Clinic, practitioners who are solo practitioners, practitioners from the Cancer Center, radiation oncologists, nurse navigators, medical residents, surgical residents. We all come together on Wednesday afternoons, and any case of newly diagnosed breast cancer or some sort of difficult to manage breast cancer can come up for discussion. We generally discuss at least 3 or 4 cases a week. The interchange is it's the coolest thing I do all week. It is It has raised all of our level of care just where we wanted it, to a level at which we could be proud that we're practicing medicine at exactly the best level it could be practiced. But the exciting thing is if you go into one of our meetings, unless you really know people, you can't tell who works where. And at the end of the day, our goal is to produce for every patient's case that's discussed a recommended plan of care that's comprehensive, that includes all the aspects of care that can be managed, whether it's radiation therapy at one end or nutrition at the other, or genetic counseling, whatever it is that's appropriate. We try to put together a plan of care for that patient. And this goes on week after week after week. We've done it now for more than 3 years. And we like to think maybe that it's the kind of model that can be extended to other subspecialties. We have plans next year to expand it into GYN oncology, to look at issues of ovarian cancer and endometrial cancer. But more importantly, I think we've all learned that, notwithstanding those first 2 organizational meetings, we can actually come together with a shared vision, and it is possible, regardless of the fact that we don't work within the same walled institution, it is possible to come together and coordinate care. So we're quite excited about it, quite proud of it, and hope to be able to expand this model.
I think our vision is really, it's not so much a vision because it's kind of been decided for us by the state and federal governments already, but what's really happening is that there's a recognition, again, with government-sponsored programs, that they want to have better coordination of care. So what they're doing is in California with plans like ours, I mentioned how they're saying we want you to do mental health benefits, and what the state is doing, they're basically, over time, giving us more and more responsibility. So if we have one of our members, we're responsible for the full continuum of care. Physical health, at least mental health, it's not the county's responsibility. And now what they're saying is we want you to move into social type benefits. One of the big concerns is, skilled nursing is one of the most expensive cost drivers. So what they want to do is they want to create as many opportunities to keep people out of skilled nursing unless they absolutely need it. So over the next couple of years, we will be assuming responsibility for state programs that deal with providing personal care to people so they can stay in their homes. There's a program we already are responsible for that used to be called the Delta Health Care. So if you have an elderly parent living with you and you work, you drop them off at a center and they're supervised, they get their medications, they can hang out with friends, and it gives respite care and so forth. And so the state's giving us all these disparate programs into one big pot, saying right now, CenCal, for your area, you manage all of these programs with the dual benefit of keeping the patient in their home as long as possible. And then 2, reducing costs by doing it that way is a lot less expensive than putting them into skilled nursing beds, which there may not be enough of. So that's something that we're going to be seeing over the next few years. Another thing is the state has said, for us, about 20% of our populations, they call dual eligible, which means they're responsible for both they're eligible for both Medi-Cal and Medicare. And so, the problem is you'd think they're both federal programs, and they don't talk to each other, they don't communicate. So within 2 or 3 years, it looks like we'll be expected to do the Medicare program for those people that are dual eligible in our area. So what you have is all the different disparate things are going into our basket, and then we're going to have to manage that care for our population across that wide spectrum. So I see that as our next 3 to 5 years.
So we promised some time for questions from the audience. Rick, do you have any? Okay, this is going to have to be a lightning round here so we can get to as many as we can. So, first question, and I'll try to direct this to somebody here. Dr. Ransohoff, is the ACA just the first step toward a single payer system?
Mike, I'd like to phone a friend. I actually think that there is a cynical view that you don't have to scratch very hard to find. That some people will say it's so messed up that what will happen is it will collapse and then it will be replaced by a single payer system. I don't know that people are that devious to have thought of that, but it is, you do hear that view expressed by people who are not stupid. So I don't know. I think that there's definitely going to be a move to better coordinated care, bundled payments, move away from the fee-for-service system. Whether that can be maintained outside of a single payer system is just not clear yet.
Okay. Let's see. Our next winner is going to be. Okay, how about Bob here? The issue of quality comes up often. Is it possible to establish nationwide meaningful standards that actually measure quality?
Well, I think there are different ways of measuring quality. From the health plan perspective, there is something called NCQA, which is it's a national accreditation health plans can get that where they have to demonstrate that quality care is provided. Now, how you define quality can be a whole other discussion. But there are things like there are measures that we submit and are held accountable to in terms of number of the children get their vaccines, is asthma being care being provided, prenatal, postpartum care, and so there is at least from the health care side and I believe the hospital side, others, there are these national accreditation organizations that seek to say these plans or hospitals or what have you have met our standards and their standards that apply nationally.
And this question is directed to Ron Werft. Obamacare was supposed to reduce emergency room visits. With co-pays in Obamacare, will visits to the emergency room at Cottage Hospital actually go down?
I don't see a connection with the ACA on that, on emergency department visits going down, unless we're able to get individuals insured and assigned to primary care physicians. I think that's going to have the biggest effect on reducing inappropriate emergency department visits is, again, getting patients into the hands of physicians where they can be better managed up front and have the screening care that they need, have early detection rather than wait and then come to an emergency department when sometimes it's too late or they need something much more expensive. I would mention that there is I think that maybe the biggest problem that we have in the emergency department has to do with the fact that for a host of reasons, the emergency departments have become the place for care and holding for the mentally ill. And as mental health funding has been reduced, and the hospital emergency departments are required, as we should be, to provide medical stabilization and to take care of any patient regardless of ability to pay. And we're proud to do that. But the way that we operate now, and this is true in every county in California and most in the country, a patient is taken or brings themselves to the emergency department. Determination has to be made if they're a danger to themselves or others, and whether they would be involuntary held and then taken to a place that can treat them. The county of Santa Barbara has a 16-bed psychiatric health facility that we don't have enough capacity in our county to take care of all the patients as they should be. And frankly, I think if you want to have a place to take a patient where they might become mentally ill, the ER is probably that place. It's not a place to cure mental illness. And so the county really needs to be credited with taking leadership and obtained a grant that could really change this. And it could result, and we hope, and we're partnering with them in this, and hope that it will result in a completely different system of providing care, not in the ER, but in a setting that makes a lot more sense for patients. So I would say those two things. Solving the mental health problem would be tremendous for our community, frankly, because it would reduce waiting times in emergency departments for medical problems. And we need to get patients insured and into the hands of primary care physicians who can take better care of them.
Thanks. We have a question for Dr. Bentley. Dr. Bentley, do you expect physician concierge service fees to grow as a trend? And if so, is that a bad thing?
Well, that's a tough one. It's hard to imagine that they would grow more than they have over the last several years. And as far as it being a bad thing, it sort of comes back to the single payer question. I'm an advocate of having patients have the ability to make choices and how their care is provided. I think concierge type of medicine is one choice. The difficulty with concierge medicine is that it limits access to a limited group of patients. So as a system, we certainly wouldn't want a predominant provider group practicing concierge medicine. But I think that it's important to have choices for patients to determine what kind of health care that they'd like to have in this new system, whether it's a multi-specialty group or whether it's in a small group practice or concierge, in one of the community health clinics. The focus really, the challenge for all of us is quality of care. Quality of care should be the same regardless of where it's provided.
I have a question for Lynda. Lynda, can you elaborate briefly on the status of the reduction threats toward hospice? Why are those being suggested, and what's the prognosis?
Specifically for hospice, the question is about?
Yes.
The hospice benefit has been one of those benefits that hasn't really been touched as far as takeaways or decreasing. And some of it, they'll say, well, Congress hasn't wanted to really touch the hospice benefit because they know that someday they may need it. So it has to do a lot with that whole hospice. So, but because everything in healthcare is now being looked at, they are looking at hospice as an industry, and there are a lot of for-profit hospices out there can make quite a bit of money. And it all has to do with what kind of care. I don't want to get into the details of payment, but it's basically paid so much per day. And for that, hospice covers all the nursing care, they cover the social work, the spiritual care, the volunteers, the bereavement for 13 months after, the medications, the medical equipment, hospitalization. So it's like a managed care plan. And if you kind of hold back on some of that care, you can make some money. And so some of the for-profits have made quite a bit of money. So now they're looking at that, and they're really adding it. They're looking at things like maybe paying more at the beginning of care and less in the middle of care and more at the end of care. Our problem here for our hospice is our average length of stay is 2 weeks. So you can't really do your job if you only have the patient for 2 weeks. So you're not going to make money. It's the long-term patients that you make money on when you have them for 6 months or 8 months. So they're looking at that. They're looking at, they've now said, in the past they said, just you had to cover the medications that are related to the terminal illness, and now they're defining that as all the medications. So they're just making some different adjustments in the interpretations, and they're looking at ways to decrease the payment for hospice.
So we're getting close to the end here. I think we have time for one more question. I'm going to use my moderator's prerogative. to choose the question, and I'll direct this toward Dr. Kass. And it's sort of a follow-up to what Lynda was talking about, and it deals with this issue of the for-profit healthcare companies and local care. And looking at this panel, the leaders in our community and the organizations that are leading healthcare in our community, you're all local. You all have service-based missions, for the most part, not-for-profit. How will or would this community be different if that changes over time? If we end up with more for-profit companies providing health care, or as part of large national chains that are providing health care?
So first of all, I actually have strong feelings about this, but primarily because I think the biggest for-profit participant in our community's health care, particularly cancer care, is missing from the panel, and not for any fault of our hosts, but because it's hard to figure out who from the pharmaceutical industry to invite. This is an immense problem. I mean, the rationale for the cost of pharmaceutical drugs has simply been based on the assumption that if the pharmaceutical companies don't make a certain requisite amount of profit, it will stunt the growth of new medicines. And yet, actually, I have just so happens, an email message that came today that I'll read. Just ask for an exception, the cell phone exception. I'll change the first name of the patient, but it doesn't matter. This is an email message to me that came at early afternoon about a patient of mine, Dolores. And there's a brand new drug in colon cancer called Stivarga, and it would just be perfect for her. It comes as a pill. It doesn't require her to come to the office. It doesn't require an expensive infusion. Something she can take at home, something she can take with her and travel. And a lot of the data suggests that this might actually really help the management of her colon cancer. So it's in our message. They don't say "Dear Fred." They just get right to it. Dolores was denied for financial help with Stivarga. Where would you like me to go from here? The cost of the medication coverage is $12,420. That may actually just be a month of the medication. That's not projected for a year. I just asked them for 30 days worth. That's just non-sustainable. I think that the beauty of this community and the time that I've been privileged to practice here is the singular determination by virtually everybody that I've worked with to make patient care first and foremost. We may all have our burdens, we may all have our frustrations, we may on some regular basis pull the phone out of the wall and then have to pay somebody to come and reinstall it. But the fact of the matter is, bottom line is, I don't know anybody in the community that at the end of the day doesn't do everything they can to make sure that our friends and neighbors get the best care possible. We've got to find a way to reform the process by which we develop new solutions to medical problems, and we've just got to find a way to control the cost of pharmaceutical drugs. The biggest failing of healthcare reform to date that I've seen is that this problem remains unaddressed, and until we address it, I think we're going to have a tough uphill struggle.
So
we wrap up our inaugural forum and bring it to a close, we do want your feedback. So please take a moment to text us feedback. Number is 242-6034. It's in your program. And please help me thank Lynda Tanner for hosting us tonight. What I think is just an extraordinary panel of thoughtful healthcare leaders that we're so lucky to have in this community. I also want to send a special thanks to the staff and volunteers of Visiting Nurse and Hospice Care and the staff and volunteers of the organizations and practices represented by our panelists and our honorees tonight. On behalf of the Board of Directors of Visiting Nurse and Hospice Care, thank you for attending the forum and good night.